How many types of classification are there, ADRs? Can you tell? Type A, type B, type A predictable, type B unpredictable. What about type C? Chronic. So best example is which is your hypothalamo pituitary suppression by your corticosteroids. Type D, delayed. The best example is teratogenicity. What is carcinogenicity? What is mutagenicity? So that is the next. E is end of use. So nothing but withdrawal. Suddenly withdrawal. If you suddenly withdraw use of your drugs. So the best example is rebound hypertension if you suddenly stop the beta blockers. So F is end of or failure of the drug. So best example is some drug interactions. I told you one good example. Can you tell? Can anybody? I have quoted one good example. Rifampicin in between oral contraceptive pills. So rifampicin is an enzyme inducer or inhibitor? Enzyme inducer. Is it not? So the metabolism is fast in case of if the woman is taking oral contraceptive pills, and if she prescribed this rifampicin for TB, so the metabolism is fast, the therapeutic failure will occur, so she will conceive. So don't give rifampicin, or otherwise if you want to give rifampicin also, but increase the levels of estrogen levels in the case of oral contraceptive pills, so that contraception will not failed. So the best way option is, though if you want to give contraception, you give the contraception. You can go for contraception, but the only ultimate is give rifampicin, but the best way is increase the dose of estrogen levels in the case of contraceptives. That is the case of OCPs. So I think this is just I have given all the 6 types of with examples: diarrhea, hypersensitive penicillins, steroid suppression, teratogenicities, so precipitation, OCP failure. So these are all main types of these ADRs in brief. So I have told what is side effect, what is toxic effect. Last time I told intolerance I discussed, teratogenicity I discussed, types of reactions I have discussed, tachyphylaxis, drug dependent. Yes, we'll go from this tech. Only some 50 minutes I require. So after that we'll go for directly to practical session. So I told you what is mutagenicity and carcinogenicity. So nothing but simple is capacity of a drug to cause some genetic defect. Suddenly it is a capacity of a drug to cause genetic defects and as well as cancer respectively. So the terminology is both mutagenicity, carcinogenicity. So many drugs including some anti-cancer drugs, though you are taking, but they will not cause cancer nowadays. But after 2 years or 3 years or sometimes after some 10 years, there is a mutations in your cells. So if you are taking some immunosuppressants, if you are taking some anti-cancer drugs, sometimes you may not get cancer immediately. But after 1 year or sometimes it may be some 4 or 10 years, there are mutations in your cancer cells. So that time it may lead to cancer or some mutagenicities. So the best example I quoted yesterday is even estrogens. If a woman taking estradiol for the offsprings will get endometrial cancer, endovaginal carcinoma of vagina. Other one is breast cancers also. If you take more estrogens, so if you are taking contraceptives for long duration of time, so some people they won't they want to contraception for a long period of time. So 10 years, sometimes they will take 15 years. So that time what will happen? This hyperestrogenism, breast cancer, remember endometrial cancer, breast cancer, it is hyperestrogenism condition. If the estrogen levels are very high, because OC pills contain estrogens. If you take OC pills for long duration of time, then there is a chance of getting breast cancer. So remember, it's a hyperestrogenism condition. Hyperestrogenism condition is a breast cancer. And I told you some even anti-cancer drugs. So anti-cancer drug itself causes cancer. So why you are taking cancer means anti-cancer drugs means you have some cancer. So that type of cancer also again some mutations in the cells. So that leads to both your mutagenicity as well as carcinogenicities. Iatrogenic disease. What do you mean by iatrogenic disease? Anybody? So it's nothing but drug-induced disease by the physician. So you are giving some drugs for a purpose of disease. That is not your fault. But only problem is, I told you in the beginning, you should give for a certain period of time only. There is a limit for everything. Like if you go for this RMPs, PMPs, they doesn't know how much duration they want to give. They keep on giving corticosteroids as well as NSAIDs. So what is the end result? They will end up in analgesic nephropathy. I have seen one man, I asked him, why your mother got, his mother suddenly renal failure at the age of only 47, 48. I asked means, sir, we went to an RMP, he has keep on giving corticosteroids for osteoarthritis, keep on giving analgesics. There is a limitation for everything. But if you keep on giving corticosteroids, keep on giving analgesics, what will happen? So at the age of his mother landed in renal failure. Now she is going alternate days for dialysis. Very painful, is it not? So even my one of the colleague, sir, your drugs, meer iche mandulu enduku pani cheyavu sir ante. RMP ma urlo unnadu. He will give one tablet, all will resolve. Definitely yes. One tablet of corticosteroid, that will resolve. But only problem is, you should give, there is a limitation for corticosteroids. There is a limitation for corticosteroids. If you give corticosteroid for 3 to 5 days, nothing will happen. Remember, ma. But keep on taking for long periods of time. So it may land up in Cushing syndrome, or you are finally used to Addison's disease, hypothalamic pituitary axis suppression. So don't give analgesics, don't give corticosteroids for a very long period of time. So for example, if you give the salicylates, corticosteroids, what will happen? So it may land up the patient may land up in peptic ulcer. So don't give any drugs for a very long duration of time. It may be some maximum you can give up to a week. Some diseases are there. So you can go even up to 2 weeks are there. Some exceptions are there. Tuberculosis. You can ask one question. Sir, what about the condition TB? Extended drug regimen tuberculosis. Can you know? MDR TB is there. XDR TB is there. What is MDR? Anybody? MDR. Anybody heard, ma? Multi-drug resistant tuberculosis. What is XDR? XDR. Extended drug regimen for tuberculosis. So only in that case, you have to give the treatment for not less than 2.5 years. Yes, it is true. Only in that case, multi-drug, leprosy also. In that conditions, it is an exceptional case. So multi-drug tuberculosis, extended drug tuberculosis, only in that case, you can go for a duration of not less than 18 months to 24 months. Sometimes in XDR, even it is reachable up to 2.5 years to 3 years. Only that is the exception for this. Otherwise, never go for any drug not less than 3 to 5 days. If you are giving an antibiotic, maximum up to 3 to 5 days. Or if you are going to some peptic ulcer disease, you can go for sometimes maximum up to some 14 days, 2 weeks, not more than that one. Antipsychotic drugs, yes, you must give antipsychotic drugs if your dopamine levels are very high. Yes, you have to decrease the dopamine levels. There is no option for antipsychotic. If the person is suffering from schizophrenia, is it not? Antipsychotic drugs you must give for schizophrenia, bipolar disorders. These are all some antipsychotic conditions. There is no option. You have to give antipsychotic drugs for long duration of time. But what will happen if you give, what is the end result? The dopamine will continuously decreases. Antipsychotic drugs, what is schizophrenia, ma? There is abnormal excess levels of dopamine. Antipsychotic levels, if you give, there is decreased levels of dopamine. You are decreasing dopamine. What will happen again? What is the end result happening? Parkinsonism. What is Parkinson's disease, ma? Deficiency of dopamine in the basal ganglia. So antipsychotics, you are supposed to give, true, very true. But what is the end result? Is it a iatrogenic disease or not? We cannot do anything, helpless. We have to give antipsychotic drugs. That's why you have to monitor the dopamine levels also sometime. Though you are giving, but you should monitor these dopamine levels. I told one good example, I told you anti-tubercular drugs. Obviously, anti-tubercular drugs, not less than 6 months. Minimum duration of anti-tubercular drugs is must be not less than 6 months. So if you are giving 6 months, what is the consequences, ma? Simply use your hepatitis. Most common adverse effect of your all anti-tubercular drugs is hepatitis. Now coming to one more organ-specific ADRs. So organ-specific ADR means which drugs will suppress bone marrow, which drugs will specifically damage renal, which drugs will specifically damage either renal or liver or heart or even ear or sometimes eyes. Can you tell one example, the drugs causing ocular toxicity? Anybody? Ocular toxicity. Tubercular drugs only? No. Ethambutol. Can you remember E for E? Eye. So eye toxicity, the drug starts with ethambutol, ETHA. So if you preparing for MCQs, they will give the mnemonic E for E. Eye toxicity, ethambutol. Even glucocorticoids. Even glucocorticoids also causes eye toxicity. There is one good question is there. Intravenous causes what type of disease? Topically causes what type of disease? So remember, I think topically causes glaucoma, intravenous causes cataract. I think just you go and just revise your ophthalmic. If you are preparing PG, you have to prepare PG. There is no option from now onwards only. I think if you ask anybody, most of them they are preparing from second year onwards. So just if there is a time, just go through all your MCQs. So even intravenous or topical corticosteroids also causes eye toxicity. Aminoglycosides causes nephrotoxicity, ototoxicity, both are there. Aminoglycosides causes ototoxicity, nephrotoxicity are there. So like that, many drugs are there specifically, or they are very meant for either liver damage or renal damage or some specifically heart damage. So these are the drugs specifically causes ADRs, like chloramphenicol. Yesterday I told you, they causes apart from aplastic anemia, they also causes bone marrow suppression. So bone marrow suppression is the first one, and they primarily causes, secondarily it causes aplastic anemia. All anti-cancer drugs, cytotoxic drugs, they will depress bone marrow. So bone marrow depression, all antipsychotic, all anti-cancer drugs. And so this quinine, rifampicin, they will cause definitely some decrease in the thrombocytes, thrombocytopenia. So liver damage, so there are so many drugs are there, but remember this methotrexate alcohol, very common cause of cirrhosis of liver. I hope you know that common cause of methotrexate is it's an immunosuppressant drug. So methotrexate is an immunosuppressant, it causes cirrhosis of liver. Even paracetamol overdose, yesterday I told, did you remember? If paracetamol gives, before, suppose if you take within 24 hours, I told you more than 10 grams. Some book says I told you 8 grams also. So roughly I have given 8 to 10 grams of paracetamol. So if you take within 24 hours, so maximum how much you can take paracetamol? I think you can go for 2.5 grams. Dolo 650, QID also you can take. Is it not? Suppose if you have some sunstroke nowadays you don't go outside, temperatures are very high. So in that case, if you want to decrease the temperature, maximum you can go for till QID. So up to 2.4 grams, 2.5 grams you can go. So what is this one? Hepatocellular necrosis. Hepatocellular necrosis, when will happen? If you take the paracetamol more than 10 grams. The correct answer is actually 10 grams, but some book says it is roughly 8 to 10 grams. Roughly 8 to 10 grams. So there is, if you tell 8 grams also no issue. Even some books also say 6 grams, but 6 grams is not correct answer. Better answer is you can say 8 to 10 grams is the dose at which it causes hepatocellular necrosis. So renal damage, I told you aminoglycosides. So this is the aminoglycosides, NSAIDs, lithium, all will causes this renal damage. Especially this NSAIDs, this actually nobody knows that it causes NSAIDs induced analgesic nephropathy. So if you give analgesics NSA, it's long term. So for example, you should suppose to take in case of rheumatoid arthritis, there is no option. But in case if you give for prolonged use, it causes analgesic nephropathy. Finally, it leads to renal failure. So how to prevent these ADRs? So avoid all inappropriate use of dose drugs. Only use appropriate dose, route, frequency. You should use correctly dose. What is the route? What is the frequency of drug administration? And you should know any previous history of drug interactions, allergic diseases. Rule out any drug interaction in the past. If you have any past drug interactions, you just rule out that one and adopt the correct administration technique and carry out appropriate laboratory monitoring is very important. So summary, this is the summary. So early detection of adverse effect, its proper management can be life-saving in many situations. So that's why we are going to do that pharmacovigilance. So that's why we are going, this question, pharmacovigilance is repeatedly asking. Last 2 years, it has been, you asked, just go through your serious question papers, they have been asking this question, pharmacovigilance. So why we should monitor the ADR report means that is pharmacovigilance is very important to decrease the adverse drug effects. So that's why this concept of pharmacovigilance came. So ADR reporting, so pharmacovigilance plays an important role in the life history of the drug, definitely. That's why pharmacovigilance plays a very crucial role in decreasing the adverse drug effects. So how to recognize ADR? So who can get an ADR? So anyone who takes medicine, definitely that so only some people can get, no. Anybody who is taking the drug can get this ADR. So when to report if symptoms occur? So when to report means appear soon after a new drug is started. Appears after an increase in the dose, disappears when the drug is stopped, or reappears when the drug is restarted. So these are all the conditions which we support to ADR reporting should be done. So ADR reporting systems, nothing but the concept of pharmacovigilance came. You should remember, we asked the definition, DAP, D-A-U-P. Can you remember the signs and activities relating to detection, assessment, understanding and prevention? We will expect these 4 terms in the Viva OC. What is pharmacovigilance means? It is a science of activity relating to DAP. I'm just telling, remember, it's a D-A-U-P, detection, assessment, understanding and prevention. And prevention of ADRs of any drug relation in the problem. So this is the WHO definition given in the year 1972. So why pharmacovigilance means you should not no harm. First, don't harm. So why you should not harm means if you harm, and again you have to treat the ADR again. So as early as possible, try to give the drug at appropriate time, appropriate dose at appropriate time is very much important in case of this pharmacovigilance. So this concept came in again first in 1980 in India. So concept of pharmacovigilance came in 1980 and DCGI. What is DCGI? Yesterday I told you, Drug Control General of India. So Drug Control General of India, it is given in national-wide monitoring of ADR in 1982. So 5 centers have been established by the DCGI. In India, it is 5. In November 1st, 2004, National Pharmacovigilance Program. This question asked. National Pharmacovigilance Program of India. They have asked for your last year question. What is this Pharmacovigilance Program of India? It is there in your Triparty, just go through it. So it has divided into 2 zonal centers, 5 regional centers and 28 peripheral centers. So this is the National Pharmacovigilance Program of India headquarters. So that is actually this one, National Pharmacovigilance Program of India located IPC we called. So Indian Pharmacopoeia Commission, Ghaziabad. It is located in Ghaziabad, Uttar Pradesh. So again they have divided CITSCO, Central Drug Standard Control Organization. Central Drug Standard Control Organization, it has divided some centers like North, South, East, West in India. So it is Chandigarh, Bangalore, Kolkata, Ahmedabad. So they have divided into first zonal centers. So these sub-zonal centers again they have divided into ADR monitoring centers. What are those ADR monitoring centers means? MCI approved medical colleges. So our college is also one of the ADR reporting center. Is there? Where is our? Have you heard about pharmacovigilance in our college? Where it is? Anybody? Hospital, anybody? Did you go? So ground floor it is there, Pharmacovigilance Center, ADR Monitoring Center, Pharmacovigilance in Santhiram Medical College is there. Go to hospital, ground floor it is there. Whenever you are free, just to go and visit our Pharmacovigilance Center is there. So it is ADR Monitoring Center. Our college is also approved, one of the approved center. So any hospitals, private hospitals, public health programs, even autonomic institutes. So these are all considered as ADR monitoring centers. So why ADR monitoring needed? So definitely you should changing the physician and patient for preference and easy accessibility of drugs and unrenewability of preclinical studies. That's why we are going for ADR monitoring centers only. So what are the various reporting types are there? So there are so many reporting centers are there, where various types of reporting types of ADRs are there. Actually in India it is Pharmacovigilance Program of India under CIDSCO. Central Drug Standard Control Organization. Central Drug Standard Control Organization. It is CIDSCO. In UK it is Yellow Card System. In US it is MedWatch. It is MedWatch in USA. So in Uppsala Monitoring Center it is located in Sweden. Finally, whatever you are uploading your ADR will finally reaches to the international system in Uppsala Monitoring Center, Sweden. So I will tell you in detail in practicals, because one more practical session is there, how to fill the ADR form. I will take one more ADR session. In that class I will discuss in detail about these systems. So need not worry this time. You just listen what is pharmacovigilance. So that time I will show you some cases are there, 5-6 cases are there. So I will discuss how to fill the ADR form also. So who can report this ADR? Some ADR report has been occurred. Who can report? Means all your healthcare professionals like doctor, dentist, nurses, pharmacist, even patient, even consumers, they can also report ADR if they have ADR reporting occurred. So problems in ADR reporting I will discuss later. How to report? So this is the ADR report form. So this is the ADR report form. So you can download in the website also. So you can download, and I will this is 10 marks in practical session now. So I will discuss in one other practical session, ADR reporting form. Separate session is there. I will show how to fill the ADR form. Just I am showing in pharmacovigilance. Next class I will show how to fill this form. So this is the ADR reporting call center. You can call to this toll-free number, and you can tell directly to this toll-free number also this ADR report has been occurred. So assessment is there. So what type of assessment is means some scales are there. Naranjo scale, WHO, UMC scale is there. So these are the scales. You need not worry about the scales. So I am going fast because I will discuss next class. Just I am showing a spot only. So these scales I will discuss in detail. So Naranjo scale. So this scale is there greater than 9, 5 to 8, 1 to 4. So this is the main scale ma. So this is the main scale we are following now. So this is WHO, UMC causality assessment scale. WHO, Uppsala Monitoring Center causality assessment. We have this certain, probable, possible, unlikely. So these are the 4 scales which you are supposed to know. I'll tell you how to assess the ADR form. Don't worry. So these are the drugs withdrawn ma. Thalidomide. Is it what is thalidomide? What it causes? Phocomelia, C-limb deformity. So this is withdrawn. Even chloramphenicol. What it causes? Chloramphenicol? Gray baby syndrome. It causes aplastic anemia, gray baby syndrome. It is also withdrawn. Aspirin in pregnant woman, it causes Reye syndrome. So that's why you should be very cautiously used in case of pregnant woman. Don't give for pregnant woman aspirin. Flecainide cardiac arrhythmia. So many are there. So you can read it. Astimazole. So astimazole, cisapride. So these are all, they have some cardiac interactions, cardiotoxicity it causes, they are also withdrawn. So go to your textbook, read your ADR topics, what are the drugs have been withdrawn or withdrawn. So just go through your Triparty, it is there. So rosiglitazone, so this is the drug for type 2 diabetes mellitus, but this drug also banned because of this getting all your myocardial infarction, stroke, everything. So this drug also banned. Gefloxacin, ofloxacin, it causes phototoxicity. I have discussed ADR also. What is phototoxicity? Which drug I told you? Tetracyclines, demiclocycline. So never give demiclocycline if the person is going sunset. So always give either in the sunset. After sunset, you can go for this tetracyclines.